My name is Jasper Brugts. I'm a cardiologist from Erasmus Medical Centre, and I will talk about TITRATE-HF. Well, with the new guidelines in 2021, it was important to study the GDMT, up-titration and sequencing order of drugs. And we especially wanted to study de novo heart failure, so patients with a new diagnosis and no chronic heart failure or worsening heart failure. And that's exactly what we did in TITRATE-HF, and it is a big cohort study on quality of care in the Netherlands. So the TITRATE-HF study is a prospective ongoing registry. It's for quality of care for heart failure patients. And basically we included consecutively about 4,000 patients with impaired LV function. That could either be newly diagnosed heart failure, chronic heart failure or worsening heart failure across 48 sites in the Netherlands. That's about 70% of our heart failure clinics. And we had an inclusion period between 2022 and 2024. So including the latest updates of the guidelines. The key outcomes are that the GDMT implementation are quite appropriate in the Netherlands. We reach GDMT levels in de novo heart failure of about 65% at 6 months. But we see that the dosing can be improved. And especially when you look at the titration of GDMT medication, after the first 1 or 2 quite active months, we see that after 2 months, the activity on up titration slows down. And I think that's a clear point of improvement for implementation research, how to keep on optimizing patients on their treatment. Well, I think it's important that you see the implementation levels off after the first initial months. That's important if you want to improve the system. But we also encountered that the heart failure care was better at heart failure dedicated clinics with heart failure nurse specialists. That's important for the system improvement. And we observed quite some LV remodeling on serial echo data from baseline to 12 months, considerable improvement in LVEF with GDMT. And also the prognosis of a de novo heart failure cohort was relatively good. And that's important for future guidelines as well. Yeah, in our study, we clearly observed that a strategy with a dedicated heart failure nurse at a dedicated heart failure outpatient clinic setting gives the best GDMT implementation strategy. But also there's room for improvement, especially considering target dose and max dose achieved. The next step is to go with subgroup analysis of the main TITRATE-HF study to look at elderly, comorbidities and gender to see any differences in GDMT implementation. And the next step for the study itself is to study implementation research. How can we go from registration of care to implementing better care? And probably we will design a follow-up study of TITRATE to really look into implementation research as a next step.